You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoy the podcast, please listen, subscribe, like, and share it with friends. Thank you. Hello, this is Richard Jacobs with the Future Tech and Future Tech Health podcast. My guest is Philippe Menasché, MD. We're going to be talking about stem-cell-derived extracellular vesicles for the treatment of heart failure. So, Philippe, thanks for coming. How are you doing?
Very well, thank you.
Yeah, so you're studying how to help people in heart failure using stem cells?
Correct, yes.
Okay, so can you give a few details on what kind of mechanisms are you trying to do this and how it's working?
Well, I think that nobody really knows how the cells are working. What it seems, however, is that the cells do not permanently engraft in the myocardium once they have been transplanted, because it has been a consistent observation that after a couple of days or weeks, they just disappear. And nevertheless, at the same time point, that is, at a time where cells have gone, you still may have a functional benefit. And this temporal discrepancy has given rise to the so-called paracrine hypothesis, whereby it is assumed that during their transient stay in the heart, cells release a wide blend of biomolecules which can harness endogenous repair pathways. And so currently many groups, including ours, are focusing on this paracrine mechanism and on the use of the molecules secreted by the cells, since it really seems that they can recapitulate the protective effects of the mother cells. So that's basically
Quick, can you restate that a little bit more simply? So when someone has heart failure, are you injecting stem cells, or are you recruiting endogenous stem cells to repair the heart? And you said they don't last long before they leave the heart, or can you recap what you said, in a little bit simpler way?
Yes, well, once you transplant cells in the heart, they disappear, they just die. And nevertheless, you get some improvement. So the hypothesis is that the repair comes from the heart itself, stimulated by molecules secreted by the transplanted cells, as long as they are present.
So are you looking for ways to force the cells to stay there longer, or to keep them alive longer? Like, do they die in the heart, or are they carried away out of the heart?
No, they not. They die in the heart, and what you mentioned is one approach that some groups are pursuing to try to keep them alive for a longer period of time. I think it's a very challenging objective for a variety of reasons, which probably we don't have time to detail. So we better try to recapitulate their protective effects by using the factors that they secrete and which probably underpin their effects. And this is what I call the secretome. That is the bulk of factors released by the cells. But what you mentioned, that is trying to keep them alive, is another approach, and I think nobody has the truth. So you just have to explore different paths and see what will happen.
So have you been able to isolate what is being secreted by the stem cells that is affecting the heart in a positive way? I mean, do you even know the mechanism? Are they using exosomes, like fluid-filled vesicles that have various things in them to stimulate the heart? Do you know how it's working?
Yeah, well, we know, it's a collective we. I mean, people working in the field know that extracellular vesicles, which are nanoparticles secreted by the cells, play an important role in intercellular communication. However, there are other factors than the extracellular vesicles. There are soluble cytokines and growth factors and so on, and probably the whole mixture is important. It's difficult to say this is the factor or this is the factor, that factor, which is the most effective. There is mounting evidence that actually you need all the factors, you need all the soup to be there to be functionally effective. But obviously, you can characterize the soup and know fairly precisely now with modern tools what is inside. What is difficult then to say is that the effect is specifically related to this or that component, but you can map the composition, yes, of the secretome and have a pretty good idea of what these cells release.
Well, are they releasing tons of different, chemicals, or is it just a
Yeah.
few? I mean, even if you
No.
can characterize it, are you still stuck?
Now, if you just focus on extracellular vesicles, for example, which is an heterogeneous class of nanoparticles, exosomes are just part of them, but other particles than the exosome, you can have more than thousands of proteins and lipid rafts and non-coding nucleic acids. So we're talking about hundreds or thousands of factors. And we know that the predicted targets of these factors in the heart can explain some cardioprotection. Why? Because some of the targets, for example, are fibrosis. These factors may reduce fibrosis as well as inflammation, which, as you know, is a very important component of heart failure. We know that other targets are angiogenesis, so these factors can stimulate the growth of new vessels. So yes, it makes sense to relate the composition of the secretome with some of the signaling pathways leading to cardioprotection.
Do the stem cells change what they secrete when they're injected into the heart, or are they always secreting it? I would guess that they're receiving signaling from the heart itself, and that causes them to change their secretome profile, and that's what's beneficial in the heart.
Well, that's an excellent point, and you're probably right. Now, probably the nature of the compounds which are released, as well as the time course of this release, is influenced by the microenvironment of the cells. What is striking, however, is that although you admit, and that's probably true, that the secretome that you can collect in vitro once the cells are cultured in a petri dish, this secretome is likely different from the secretome which is released in vivo once the cells have been transplanted. And nevertheless, across a very wide variety of preclinical models, not only in the heart, but also in the brain, in the liver, in the kidney, in the eye, you can have, for the studies which have used head-to-head comparisons, you can have really similar effects by transplanting the mother stem cells or by injecting the cell-derived secretome. So even though, once again, you're right, the secretome that you collect in vitro is probably not exactly the one which is released in vivo, at the end of the day, when you use it appropriately, it can have positive effects which equal those of the mother cells.
Oh, so it's essentially good enough or close to being good enough by, in a petri dish, having the cells generate some secretome, and that being injected works.
Yeah, well, what do you mean then?
Well, again, you said in vivo, the stem cells, the profile of what they secrete is a bit different from what they'll
Yeah,
do it,
probably.
in a petri dish. But is it quote unquote good enough where it can heal the heart enough that it makes a big difference?
Well,
Or does it have to be in vivo?
no, at the end of the day, as I just mentioned, the outcomes are similar. So I would
Okay.
say it's enough. It's enough to collect appropriately the secretome in vitro to recapitulate, to duplicate the cardioprotective effects of the parental cells.
Okay, so is this robust enough to be like a protocol that's being used, or is it still a long ways to go for it to be effective?
Well, probably some way to go, but our group, for example, is already in the process of the so-called translational phase to adapt bench techniques to procedures that could be used in humans. And we're actually planning for a clinical trial. I can't tell you when exactly. It depends on a couple of things. But extracellular vesicles, for example, have already been used clinically, and you already have a bunch of clinical trials using extracellular vesicles in settings different from heart failure. But I mean, it looks safe, at least in the indications in which they have been used. So I don't think it's something completely unrealistic, even though there are still a couple of unknown factors that need to be addressed.
Well, okay, so you're injecting this material directly into what, the wall of the heart or the damaged muscle?
Well, they're
Where
different.
is this going?
Okay, there are different approaches. I don't think that the snapshot injection in the heart is likely to be very beneficial because you can anticipate that the fluid that you inject will be rapidly washed away. So if you inject directly in the heart, and this is something that can be done, for example, during a cardiac surgical procedure, and just remind you that I am a clinical cardiac surgeon, you can, and this actually is being done experimentally, and we're working on that, you can functionalize a biomaterial and use the biomaterial as a platform which will release your secretome over time in a controlled fashion. So that would allow the myocardium to be exposed to the secretome for a much longer period of time. Now, there are other approaches which are currently under investigation. Nobody really knows what's going to come out from there. But I think these are interesting approaches worth to be explored. And this is the intravenous approach. One big advantage is that it's a non-invasive approach, and as such, it can be repeated. And probably repeating administrations of the secretome, or actually of the cells, is something which has been shown to be beneficial. I think that it's doubtful that a single delivery of cells or of the secretome can really have long-lasting therapeutic effects. So we are actually extensively working now on the IV approach, precisely in the perspective of repeated deliveries.
What about just flowing the cells through the heart as blood flows through the heart? Are you able to upstream of the heart? What if you just injected a whole bunch of stem cell derived vesicles with the secretome in them? They flow through the heart and out. Would that be enough to cause any effect, or does it have to be injected into the heart wall, into the heart muscle in certain spots?
I don't have the answer for you because I'm not aware of any study which has really looked at this approach. I think that if you reason my analogy with what has been shown when you inject in the coronary arteries bone marrow stem cells, for example, as it has been done in patients with acute MIs, really your cells don't stay in the coronary vasculature, and they're just washed away. And at the end of the day, they are found in the lungs or in the spleen or in the liver. So I'm not sure that this would be the most effective way of having your cells or your secretome reaching the heart. Now, there is another approach which is currently being considered, and which consists of engineering the extracellular vesicles with ligands which target receptors expressed on the heart, just to accelerate their homing to the areas of injury when you inject them intravenously. And this is something I think very interesting.
Well, what makes the cells die? How long does it take, and what
Um,
actually is the cause of death? Are they denied nutrition? Are they being signaled to undergo apoptosis? I mean, what's the mechanism?
yes, there are different factors. Number one, they incur a real physical stress at the time of the injection. Just look at the size of a syringe and the size of the needle, and you can easily understand that they undergo a terrible shear stress, which is damaging for them. Number two, as you just mentioned, by definition, you put them in areas which are pretty vascularized. And so they will obviously miss some oxygen and nutrients to keep them alive. Number three, the injection by itself creates a local inflammation, which can also be damaging for the transplanted cells. Number four, if you're using allogenic cells, you can trigger an immune response, which will further contribute to cell death. And last but not least, when you inject cells in suspension, they lose the survival signals associated with their anchorage to an extracellular matrix. And the fact that they are just floating free without attachment to a matrix is something which also contributes to their death. So as you see, there are multiple causes of cell death, and that's why trying to tackle each of them for keeping them alive for a long period of time is really a challenging task.
So I'm sure some groups are trying to, I guess, maybe do a small implant of a patch that represents an extracellular matrix that the stem cells can sit in, and then they avoid the shear of being injected, and maybe perhaps that they would live longer that way.
They would, and this has been extensively tested in the embryonic stem cell trial, clinical trial that we completed now 2 years ago. The study was completed 2 years ago. The cardiac cells that we have been using, and these were cells derived from human embryonic stem cells, were actually embedded in a fibrin patch, just as you mentioned, with the idea to keep the cells alive for a long period of time, which actually probably happened, but not to the point that they would survive forever. So you just, lengthen the period during which they may be present, but you don't really succeed in keeping them fully alive in large amounts, at least for months or years. But definitely, if you are using stem cells directly in the heart, as we do in surgery, it's probably a much more efficient way to do as we have done with fibrin, but you can do that with any kind of biomaterial, honestly, synthetic or natural. It's much more effective to incorporate cells in a biomaterial acting as a platform than injecting them just straight ahead, because then you're sure that many of them are going to die very rapidly.
Well, how long do they need to live to be effective? What's the ballpark?
Well, this is also a difficult question. Nobody really knows how long they have to be there for having enough time for releasing the factors. But people are talking about a couple of days or weeks, not months. And we had, fixed the time limit to 4 weeks in the clinical trials that we've been doing. That's why we gave immunosuppression to the patient just for 4 weeks. But maybe it's much quicker. It might be much quicker because it's known that if nanoparticles, extracellular vesicles, and exosomes are key mediators of the protective effects of the cells, they can be shuttled to the recipient cells to deliver their cargo very rapidly. It's a matter of hours. So maybe the cells don't need to be there for a very long time to really be effective. But the precise time limit has not been really defined.
Well, I mean, how long does it take for the heart to heal to various percentages? On average, does it take a month to get to 50% better, or and I'm sure it has diminishing returns over time.
You mean once you have injected the cells, how long does it take for them to demonstrate their therapeutic benefit? If it's the question, you probably have to wait at least 1 or 2 months. It's not something that happens too rapidly. usually it's thought that between 1 and 3 months, you could start to see an improvement, if there is an improvement. That's the order of
Where do
magnitude.
where do the stem cells come from in the heart natively? Where are they kept in the heart? Are they all over the heart in various tissues, or are they in a certain spot?
Well, first of all, there are serious discussion as to whether there are stem cells or not in the heart. See, that's the first point. And you're aware of the controversy about a c-kit story and all the problems with Harvard, with the retraction of the papers, claiming that the heart harbored c-kit positive stem cells, which has been shown not probably to be true. Now, if there are stem cells in the heart, they're probably located in very tiny niche in the left ventricle, possibly also on the right side of the heart. But the precise mapping of these cells has not really been done. One reason being that there is still the question as to whether the heart really harbors stem cells or not. And so it's difficult to definitely answer your question.
Yeah, I just didn't know if they travel a certain path from a certain place to a certain place, and how many different types of stem cells there are in the heart, and why they're active for certain, issues in the heart and not active for others. I don't know if is there a lot of knowledge there, or is there so much to know that it's hard to figure it out?
No, what is known is that probably at the time of birth, there are stem cells which are able to heal an area of injury. And this has been shown in congenital heart surgery, for example. But it seems that after a couple of weeks of life, these stem cells disappear. And that, again, it's not sure that the adult heart, in particular, if the adult heart has already been challenged by an injury, whatever it is, it's not sure that these stem cells persist through adulthood. So the only thing which is pretty sure is that we are born with a small capital of stem cells in the heart, but it really seems that this capital is rapidly exhausted after birth. And this has been very well shown in mouse models. If you amputate the apex of the left ventricle in a neonatal mouse, it will heal and regenerate completely. Now, if you wait for, say, 8 days after birth and you do the same procedure, the amputation of the apex, then you will get a scar.
So is there zero healing in adult hearts, or is there only a small amount observed?
There is some spontaneous healing facilitated by inflammation, but by definition, this healing is not enough to prevent heart failure in many patients. So the endogenous capacity of the heart to self-repair is not sufficient for avoiding, severe dysfunction of the pump, and that's actually the basis of heart failure. And this is also the main rationale for providing stem cells or the secretome of stem cells to try to boost these endogenous pathways, to awake them, so to speak, if it is possible. At least this is the underlying hypothesis.
Well, the reason I ask is maybe there is a little bit of healing going on, but competitively the scarification wins out. So maybe there's a way to dampen the scarification to allow the small amount of endogenous healing to occur. Maybe that's another path. That's why I asked if there's any healing at all.
Well, you're right, and this is one of the postulated mechanisms of either stem cells or their byproducts. That is to mitigate the development of fibrosis, and so to allow the heart to be more flexible, less stiff, and to pump better. So yes, this is one of the targets.
So what's the end goal with your research? What would it look like if it was, highly successful? What elements would it need to have about it?
Well, the story is that, as I just briefly mentioned, we completed this first-in-man clinical trial using human embryonic stem cell derived cardiac cells, cardiac progenitor cells. And we found, as others, experimentally at least, at the time I was doing the study clinically, but we found in the lab that these protective effects of our cardiac cells were really duplicated, could be duplicated by administering the secretome of the cells. So now what could be a success for us is just to keep the cells but outside of the body, just to use them as ex vivo bioreactors, biofactories, and take the secretome. That's exactly what we are currently doing, and giving in repeated fashion the secretome to patients with the hope of improving their outcomes. So this is the objective, and obviously if it does work, that will be very successful. But whether it will work or not, I don't know. This is ongoing research.
Well, so how long are you able to keep the cells alive? And you said another approach was to do repeated injections, where they last just long enough, continuously enough to keep the healing going.
What I mean is that repeated injections in our protocol, future protocol now, is repeated injections of the secretome. So it's not an issue to keep the cells alive in culture and having large numbers of them secreting large volumes of secretome, which can then be cryopreserved and used as an off-the-shelf product. This is very much more convenient in terms of practicality.
So where are you at with the trial? Have you tried this in humans yet, or are you not at that point? Is it just being done in mice?
No, I told you we are in the translational phase. That is, we have designed the methods in the lab. We know exactly what we want, and we are now transferring the procedures from a lab bench, setting to a GMP facilities certified for human use. So we are really now adapting the procedures, and we still have a lot of quality controls to ensure that the product is reproducible and so on. So, but we are really in this phase which precedes, hopefully, a phase 1 safety and feasibility trial, hopefully not in not a too long time, but I will be very cautious regarding calendars.
Right, of course. Who is the ideal candidate for this in your mind? What kind of heart disease and how far along, and what are some parameters that you think would make a good candidate?
Well, I think heart failure is obviously our target indication, and probably not exclusively ischemic heart failure, which has been the subject of most clinical trials so far, but also non-ischemic cardiomyopathies, which, as you know, are very frequent now, and for which therapeutic options are actually more limited than for ischemic conditions. So this is the kind of patients that we are targeting.
So ischemic meaning you have a heart attack, part of the heart tissue dies and scars over, and this happens X number of times and reduces the heart function to the point where now it's failing. That's ischemic, right?
Correct.
And then cardiomyopathy, just how does that happen? Just briefly.
Well, if you have massive destruction of a large area of the heart, obviously you lose million, not to say billion, of cardiomyocytes, contracting cells, and you get a deterioration of the pump function, and the heart dilates, and then you get into heart failure. So this is really the condition which we are dealing with, and for which we are proposing this new therapy.
Okay. Well, very good. Any nuances about this process that we haven't discussed that are surprising to you, or feel like it's going to be a critical part of the process, or it's just a very it's just a surprising thing to you that you discovered?
Could you just explain what you were?
Anything that you've in your research, what surprised you most? Is it that the number of different chemicals and things in the secretome itself? Is it what surprises you most about what you do?
Well, the surprise actually, because this was rather unexpected, although some people had raised this paracrine hypothesis long ago, but the surprise was really that it seemed that the effect of the cells could be reproduced in a simpler way by injecting, say, the cellular juice. So this has been a surprise for us. Now, it doesn't mean that using the secretome is much simpler than using the cells. Let's say that the technical challenges are different and might be at the end of the day easier to tackle, but it's not really something trivial as well. But once again, the surprising thing is that just by injecting a bunch of factors, you can possibly reproduce what has been done with the stem cells themselves.
Okay. Well, very good. Well, what's the best way for people to find out more about the work and to keep tabs on, when the phase 1 trials will begin and get in touch?
Well, regarding the phase 1, there is nothing published so far. We've published a couple of papers about extracellular vesicles. We have another one which is going to be submitted within the next days or so, showing that the secretome, for example, doesn't seem to be immunogenic, which is important because it should not be rejected. And so just looking at PubMed and doing exosomes and heart failure, or eventually typing my name might lead your readers to some key papers summarizing what has been done in the field so far. I've also written a couple of general reviews, which eventually could be useful for those interested.
That's great. Well, Philippe, thank you for coming on the podcast. I really appreciate it.
Well, thank you very much for the invitation.
You're listening to the Future Tech Health Podcast with Richard Jacobs. Until I reached age 40, I never realized the obvious, that we all have medical issues, or we at least have a family member or close relation that has, or will have them in the future. Medicine and biological systems are the final frontier. Until we've conquered death, figured out how life began, cured cancer, and understood our purpose in the universe, there's a heck of a lot to talk about when it comes to our health. Future Tech Health means I'll be covering futuristic topics that are actually already in clinical trials, or even starting to appear on shelves or by prescription, or available for your own use. We dive deep into stem cells, CRISPR-Cas9, the science of sleep, epigenetics, medical testing, cancer, ketogenic diets, stem cells, aging, regenerative medicine, and more. My goal for you, the listener, is to learn from these podcasts. You may very well learn something that may change the course of your life for the better, steer you towards a new career, or give you insight into addressing a serious medical problem. Remember, however, this podcast and its content is informational in nature only. No medical, tax, legal, financial, or psychological advice is being given. If you enjoyed the podcast, please listen, subscribe, like, and share it with friends. Thank you.